welcome Tony Morrison.
Thank you very much for the kind introduction and the invitation. I'm relieved from your introduction that it is me rather than the Nobel Prize-winning American author that you were inviting, because I've had a few invites recently that make it very clear that they've got the wrong Tony Morrison, as it were. So what I'm going to talk about today is a kind of brief overview of the sort of cost-benefit profile of antipsychotic medication. Briefly outline the approach that we take to understanding psychosis from a cognitive model point of view, and then look at evidence regarding the effectiveness of that approach in terms of delivering therapy to people without antipsychotic medication. And as Don said, been involved with a couple of nice guideline development groups recently, and we'll talk particularly in relation to the children and young people and psychosis guideline, which is available in draft form on the internet. As is often the case, lots of what I talk about will relate to work that has been done by a much wider team. So some of it will relate to the EDDI trials that we've done, which includes a cast of many, and also some of it will relate to the action trial, which is currently running between Manchester and Newcastle. I'm going to be talking about sort of delivering psychological therapy to people with psychosis. I guess it's important to emphasise that from a collaborative therapy point of view, we only work with people in relation to distressing psychotic experiences. If they're not distressing, wouldn't want to do anything about them. From the overview of antipsychotic medication that I'm going to run through, people might think that I'm not a fan of antipsychotic medication. And I want to highlight at the start that that's not the case. I've worked with many people over the years who've derived significant benefit from antipsychotics, including friends and colleagues. But I've also worked with lots of people who derive no benefit from antipsychotics, and the current sort of psychiatric service response is usually to try and encourage or coerce people to carry on taking them when they don't. So I think if antipsychotics are helpful for people, that's a very nice thing, but if they're not helpful for people, then people should be able to make choices about that. So it's the over-reliance, or often what we see is the exclusive reliance, where antipsychotics are the only choice that people are offered, that I'm not keen on. I get very worried whenever I see that photograph. The data that I'm going to run through is summarised in an editorial that was published earlier this year in the British Journal of Psychiatry. Colleagues that I wrote it with include David Shires, who's a retired GP now. He has a daughter who developed psychosis at the age of 15, which encouraged him to, amongst other things, write with some colleagues and friends the Early Psychosis Declaration, which has inspired a lot of the early intervention work that's gone on. And he obviously has a very strong personal interest in improving things for people with psychosis. So if we look at antipsychotics, one of the most striking findings is that people don't like taking them. The Katie trial, which this is the largest trial of atypical or second-generation antipsychotics to date, conducted in North America, and the headline finding was that 74% of people stopped taking their antipsychotics before the end of the trial. So 3 out of 4 people who start taking antipsychotics stop taking them before medical advice recommends them. So having a sort of mainstay of treatment that 3 out of 4 people won't take doesn't make an awful lot of sense. In terms of how effective antipsychotics are, there is clear evidence that they are better than placebo, but not necessarily as strongly effective as we might hope. So this is a large meta-analysis of second-generation antipsychotics compared with placebo, conducted by Stefan Leut and colleagues, who is one of the world-renowned experts on antipsychotic medication. And what they found was, across all the studies, 41% of people showed a good clinical response to antipsychotics, but 24% of people showed a good clinical response to placebo. So it's not necessarily as big a difference as you might think. In addition, that gives us a number needed to treat of 6, which in medicine is pretty good, but it still means that of every 6 people we give an antipsychotic to, 5 people won't show a good clinical response. A systematic review of drug trials published in the British Journal of Psychiatry last year looked at over 200 drug studies for people with a diagnosis of schizophrenia. And what they found was that the vast majority of those trials didn't show even minimal clinical response defined using the PANSS. So the PANSS is the most common kind of psychiatric interview used to examine efficacy in both drug and CBT trials for people with psychosis. And Stefan Leut has done some work suggesting that you need a change of at least 15 points on the PANSS to equate with a kind of observable clinical change, and most of the trials that they looked at didn't show that. This is a quote from the summary of the Cochrane review for risperidone, which, for those of you familiar with Cochrane reviews, they don't often say things like this. Essentially saying it might help people, but the data doesn't suggest that that's the case, and people who have been prescribed risperidone might want to ask some questions and be a bit annoyed about the situation. Looking at the Cochrane reviews for antipsychotics in more detail, because we were looking to equate the effect sizes we were getting with CBT without antipsychotics with the effect sizes of the drugs, Paul Hutton, who's a colleague of mine that I work closely with, looked at the 5 most popular antipsychotics Cochrane reviews to look at the effect size. When he started reading them, he started to notice lots of mistakes. So we looked at them systematically in a lot of detail. This is a very busy slide, which I apologise for. But basically, most of the Cochrane reviews say that they will exclude trials with over 50% attrition. So if you've got more than 50% missing data, in one way or another, most of your data is made up. So you'll make assumptions about it or use last observation carried forward. But all trial methodologists would suggest that a trial with more than 50% of attrition isn't worth looking at. So the Cochrane reviews say they'll exclude trials with more than 50% attrition, but then go on to include them and don't highlight that fact. If you exclude trials with more than 50% attrition, for olanzapine, which is probably the most popular antipsychotic, there are no studies with less than 50% attrition in comparison with placebo. So essentially the data to suggest that olanzapine works better than placebo isn't there. And if you think about the billions of pounds that drug companies make from antipsychotics, It's a rather worrying state of affairs. If you look at risperidone and apply what most trial methodologists would consider reasonable, which is excluding trials with more than 25% attrition, you actually find of the 17 outcomes that they look at, 6 of them favour placebo and only 4 of them favour risperidone. So if you look at the good trials that have a sufficient amount of data that's actually real, you get a rather different picture from what the Cochrane reviews suggest currently. Another thing to think about is the kind of size of difference between risperidone and placebo. So this is a trial that was a good trial done on about 300 children and young people looking at aripiprazole. And from the forest plot, it's clear that it's well away from the line of no effect, favouring the drug. So there is a detectable benefit statistically. But if you look at the size of change, the primary outcome was the PANSS. So you get 26 or 28 points change on the PANSS if you take the drug. But if you are on placebo, you get 21 points change. So if you think about the 15 points for a good clinical response, people are showing, on average, a good clinical response to placebo, and the difference between placebo and the drug is only 5 or 7 points, which is not a detectable or observable difference. So the evidence for the effectiveness of antipsychotics isn't as strong as we might have hoped. What about the adverse effects? There's a systematic review been done, looked at 26 studies examining the structural effects of antipsychotics on the brain, and what they conclude is that the antipsychotic drugs reduce the volume of brain matter and increase ventricular or fluid volume, and the antipsychotics may cause some of the structural changes that were previously attributed to the syndrome of schizophrenia. That's been replicated by Nancy Andreasen, who's a very influential biological psychiatrist in America, using a prospective longitudinal study, and they concluded the same thing. A study done in the Netherlands showed that if people discontinue antipsychotic medication, their neurocognitive functioning improves, which again was quite surprising. I'm sure everybody is aware of the weight gain associated with antipsychotics. It's very dramatic, particularly in the first year or two. Possibly resulting from weight gain and other cardiovascular and metabolic effects, there is indisputable evidence that antipsychotics increase the risk of sudden cardiac death. And what's particularly worrying, thinking about children and young people, is that the cardiometabolic risk factors are detectable after the first administration of an antipsychotic. So the first time you take it, you can detect elevated cardiometabolic risk. Not surprisingly, as a result of some of those things, people with a diagnosis of schizophrenia have significantly reduced life expectancy, about 20 years for men, 15 for women. And there's lots of suggestions about stopping smoking, promoting exercise, and screening people properly, which all makes sense. But I guess offering people choices other than antipsychotics, particularly if they're not deriving benefit from them, would also be a sensible thing to do. It's also clear that if healthy people take antipsychotics, they can develop what are known as negative symptoms like apathy, avolition, flat affect. So I guess it seems pretty sensible to investigate choices for people with a diagnosis of schizophrenia. It's pretty clear that they want things in addition to or other than medication. But there's very little evidence around what might work for people not taking antipsychotics. If you think about, things like, Jamie Oliver's campaign around school dinners, if the only thing that was available on the school dinner menu was custard, people would be up in arms about it, and parents would be furious. And there would be national campaigns and outrage and all the rest of it. Whereas, if you're a parent of somebody with something much more serious than school dinner choice, in terms of first episode of psychosis, we're pretty much, certainly large pockets of the country, are in the position where there is only one option, and everybody's told it's custard or nothing, essentially. One thing that you can do to try and help promote choice is shared decision making. So there are interventions that will help people to make informed choices, and it's very clear that people with psychosis most of the time retain decision making capacity. And you can deliver interventions to help people make those choices and weigh up costs and benefits. This has been done in Germany. Great idea, but I think it emphasises the need to address environmental and sort of system change as well. I suspect you won't be able to read it. I can barely read it. But one of the conclusions of this was patients in the intervention group became more sceptical of treatment after hearing all the evidence, and were perceived as more difficult by their psychiatrists. So if we are going to try and promote informed choice and consent in people that retain decision-making capacity, we need to do so within a system that will respond in a positive way, rather than perceive people as difficult and potentially become punitive. So I shall move on now to talk about psychological things. Cognitive therapy, I'm sure everybody's aware, is a collaborative, problem-orientated approach. The principles of the particular approach that we take very heavily influenced by work that was originally and now again being conducted in Oxford by people like David Clark, Paul Sharkowskis, Adrian Wells. I was lucky enough to be a research assistant here many years ago, and what I took from that time was in order to deliver effective treatments, we need an accurate, empirically validated model on which to base those treatments. The messages, I think, in their work for service users, very applicable to people with psychosis. Probably the strongest one being the normalising message. People with psychosis worry that they are mad, and unfortunately the traditional response is to agree with them, and that's not a terribly helpful message for people. Helping people to understand that their difficulties are understandable responses to things that have happened to them, and the way they're appraising events is very important. The idea of theory 1, theory 2, either it's real or you believe it to be real, is very applicable to working with people with psychosis. So either you are being persecuted by a terrorist organisation or you believe you are, and either of those makes sense of how you feel. The emphasis on testing things out by changing responses and dropping safety behaviours is also very applicable. So that all those kind of principles we apply in our work. The cognitive model that we base it on was published about 10 years ago. A more friendly version of it looks at the way life experience affects how we see ourselves, the world, other people, and how those beliefs affect how we make sense of ongoing events, and how that relates to how we feel and what we do in terms of both cognitive and behavioural responses. Got evidence for the different hypothesised relationships between those different factors. And we'll talk through a case in more detail later on to try and illustrate it. There'll be a few slides with quotes from our service users. Rory Byrne, who's a colleague of mine, who was a participant in one of our first trials, has just about finished a PhD that consisted of lots of qualitative studies attached to the various trials we've done. And you can hopefully see from those quotes that people who've received cognitive therapy for psychosis think that the kind of principles around things being understandable responses to life and developing formulations based on the model is a helpful thing to do. The kind of approach that we take in the different studies that I'm going to outline tends to be around about 26-30 sessions over a reasonably lengthy period of time, 6 months for the people at risk of psychosis, 9 months for the people with established psychosis. And it's very active sort of from the start. We try and develop early shared goals, formulations related to that, and then get going with change strategies quickly to try and reduce distress and improve quality of life. Another quote from one of our service users gives you the idea that we're not trying to get rid of psychotic experiences per se. They're not necessarily pathological. It's about helping people to reduce their distress and improve their quality of life. In some ways, trying to get rid of something like voices might be a bit like trying to get rid of body sensations in somebody with panic. It's not the experience, it's the appraisal and response that we need to work on. In terms of the common treatment strategies, looking at the advantages and disadvantages is something we place a lot of emphasis on, partly because the service users that we're working with are the people that have to live with the consequences of any changes, and psychotic experiences often are associated with benefits for people. Hearing voices, for example, might provide company for people or advice. There's obvious advantages to being paranoid in certain circumstances, and lots of the social environments that people that we work with would foster kind of concern about interpersonal threat. Again, giving people choices and informed consent about making those changes is important, and all the other things that you would expect to go along with cognitive therapy. And again, service users seem to, after the end of therapy, recall the kind of strategies, emphasis on testing things out, and examining evidence, generating alternative explanations, etc. So, NICE guidelines suggest that everybody should be offered CBT for psychosis. I'm sure you're well aware that we're a long way from that being the reality, but it would be something to strive for. If you look at meta-analyses of CBT for psychosis, it's clear there is an effect. It's not necessarily as strong as we might hope, so the effect size is probably about 0.4, particularly if you look at the more methodologically robust trials. That's about the same effect size as antipsychotics, but if you look at meta-analysis like this, all of those trials have been done in addition to antipsychotics. So people were receiving CBT plus medication. We've done a trial, currently published a pilot trial of 20 people who weren't taking antipsychotics, had chosen not to, and sort of had a schizophrenia spectrum diagnosis, had either never taken antipsychotics or had not taken antipsychotics for the last 6 months at least, and had to be scoring as symptomatic on the PANSS. In terms of the effect size, they were fairly encouraging. So end of treatment on the PANSS total, which is the most commonly used primary outcome, the effect size was 0.85. They were all around about that sort of size. and they were looking slightly better at follow-up. So the PANSS total effect size at follow-up was 1.2. That's likely to be inflated because it was a single-arm trial, lots of potential for bias. In terms of statistical significance, things were changing, and if you look at the PANSS total scores, about 10 points change at end of treatment, and getting on for 20 points change at follow-up. So certainly at follow-up it was looking like a good clinical improvement. You get the same sort of pattern for just looking at positive symptoms, just looking at delusional beliefs using the CIRATs, similar for voices. In terms of secondary outcomes, we also looked at sort of user-defined recovery and social functioning using the PSP, and we found significant effects at follow-up for both of those, and a significant effect at end of treatment for functioning. So it's not just symptoms that we're getting effects on, it's also things that are actually more important to service users themselves. The QPR is a recovery measure that was developed by service users, looks at things like improved relationships, feeling better about yourself, and optimism about the future. In terms of percentage change, we were getting what would be viewed as very good clinical outcomes, so 50% improvement or more on the PANSS in 7 out of 20 at end of treatment and 10 out of 20 at follow-up. So fairly encouraging. Only 3 people started antipsychotics throughout the time of the trial, and those 3 were in the poor responders in terms of percentage change on the PANSS. So it's very clear that the benefits that people were getting aren't attributable to people having started medication. We did some work looking at things that might predict response to cognitive therapy, and we found that change in appraisals around paranoid experiences, paranoid thinking, and change in appraisals of voices in terms of what they meant and how controllable they were, did seem to correlate in the expected direction with change in symptoms. So modifying those appraisals seemed to be associated with change both at end of treatment and at follow-up, and shorter duration of problems and younger age, certainly at end of treatment, younger age was associated with some of the outcomes as well. So again, for children and young people, that's particularly optimistic. But as I've said, lots of potential for bias, so we need to do a randomised controlled trial, which we've called ACTION, which is assessing cognitive therapy instead of neuroleptics. I preferred our initial acronym, but was banned from using it because it was too rude. So for those of you that can keep up, it was the North of Britain Treatment Without Antipsychotics trial. 2 sites, Newcastle and Manchester. We've ended up recruiting 74 people, assessed 143. Interestingly, of all of those people, only 3 people declined involvement in the trial after being assessed as eligible. So clearly much more acceptable to people than antipsychotic medication, or certainly people who are choosing not to take antipsychotics find this a much more acceptable thing, which was quite surprising. In terms of the baseline characteristics of our sample, I won't go into the details, but basically, as you might expect, because they're not taking medication, they're actually a more severely troubled population than the CBT for psychosis plus antipsychotics trials. So their baseline scores are actually higher. So certainly we won't be able to be accused of only working with people that were well. In terms of reasons for not taking antipsychotics, it's, as you'd expect, a combination of side effects, previous lack of efficacy, and kind of philosophical objections, if you like. So either not wanting to take medication or viewing your difficulties as of psychosocial origin in relation to life events and trauma and so on, and therefore not understanding why medication might be useful to you. That's particularly interesting, I think, given a paper that Dan Freeman published recently from the PRP trial that suggests that people's causal beliefs about the development of their psychosis seem to be associated with outcome. So if people viewed their difficulties as of biogenetic origin, they didn't appear to respond terribly well to CBT. If they believed their difficulties were of psychosocial origin, they responded well and derived benefit. And I guess if you think about offering choices to people, again, it makes a lot of sense. If you view your difficulties as biological, you'll want to take medication and might well respond well to that. If you view your difficulties as psychosocial origin, you're probably going to want psychological therapy and might be more likely to respond to that. So again, I just think it emphasises the importance of provision of choice for people. In terms of the current state of play around the draft NICE guideline, it's not worded terribly optimistically, so it says tell people that there isn't any evidence to support psychological interventions without antipsychotics, which is true because there haven't been any trials done, but it does allow people the choice to not take antipsychotics and just receive intensive psychological interventions in terms of CBT and family intervention. So we're currently trying to get it worded a bit more positively, but certainly the choice is going to be embedded within the NICE guidelines. And I guess that has quite significant implications for services. So I've been very frustrated over the years. A number of friends of mine have had children develop psychosis, and I've been roped in a kind of advocacy role and attending ward rounds and so on. And children and adolescent services are very short on people equipped to provide psychological interventions for people with psychosis and their families. And typically the response is that the clinical psychologist gets involved in doing neuropsychological testing of the young person. And I think the evidence would suggest that there might be more useful things that we could do with our time. Just relating to the lack of evidence about antipsychotics compared with either placebo or psychosocial interventions in young people with first episode psychosis. The Cochrane review for that was published last year only found 6 studies ever done and concluded that virtually all of them had no usable data. But at least one of those 6 studies found that psychosocial intervention was actually better than antipsychotic medication. So again, much less clear-cut picture than we're typically led to believe. There are currently, as well as our study of people choosing not to take antipsychotics, in Australia they are doing a trial of CBT in comparison with antipsychotics, in comparison with both. But they've struggled in terms of recruitment and stalled the trial for a while. So I think they've currently got 6 people randomised in the trial. But it's encouraging that that sort of research is beginning to happen. I guess it's important to emphasise that CBT for people with psychosis isn't a panacea. It's not for everyone, and certainly from the interviews that Rory's done, he's elicited certainly adverse effects in terms of increased distress, particularly around disclosure of difficult traumatic life events and so on. And very clearly some people have said it's very hard work, and there are times in my life when I wouldn't have been able to do this. So again, it's important to offer choices but not expect everybody to take it up, and make a variety of options available to people. And that should include family intervention. I should say that, or Juliana would shout at me later. Just to finish, we'll look at the evidence around prevention of psychosis. We've done a couple of trials over the years trying to use CBT without antipsychotic medication to prevent a first episode in people who are at high risk. Basically, Alison Young, who's Professor of Psychiatry, was in Melbourne, now in Manchester, has developed criteria that involves being a young person and either having a first-degree relative with psychosis or low-level attenuated psychotic symptoms or brief kind of severe psychotic symptoms that resolve without medication. Her original research suggested that about half of those people meeting that criteria would develop psychosis over a fairly short period of time. Current research would suggest it's much more like 1 in 5, maybe even 1 in 10, but certainly more than, much higher than the risk of the general population. That led people to start to think about intervening. The problem is detecting a observable effect with a fairly low frequency event. So if it's 1 in 5 or 1 in 10 people, you need an awful lot of statistical power to show an effect. Our most recent trial, which had nearly 300 people in it, didn't notice a statistically different effect. But if you put all the trials together, which NICE have done, conduct a meta-analyses, the forest plot clearly shows that there is a observable effect, and it appears to reduce transition to psychosis by about 50%. So the risk ratio is 0.55. If you look at the studies that involve antipsychotics as well as CBT, putting them together doesn't show a statistically significant effect. There are less of them, so there's less power, but I think it's pretty clear that there isn't anything to be gained by adding antipsychotics into the equation, and there's potentially quite a lot to be lost, as it were, by doing so in terms of exposing people to the adverse effects. It's also very clear from the trials that have included antipsychotics that many more people drop out than in comparison with the psychosocial trials. So as a result of that, the current draft of the NICE guidelines suggests that people should be offered CBT, and categorically they should not be offered antipsychotic medication if they are at risk of psychosis. Some people have raised concerns about stigmatising people who are at risk of psychosis. So even by delivering CBT, we may be, labelling people in some way, bringing them into contact with services, which I think is a serious risk that deserves consideration. Having looked at stigma in our trials, it's very clear that there is no difference when people come in at baseline to the trial between the people who are at risk of psychosis, never received a diagnosis, not had a label attached to them, and the people with established psychosis with a diagnosis of schizophrenia. So it's pretty clear that when young people start to experience unusual phenomena like hearing voices, starting to worry that people might be going to cause them harm, because they are part of the general public, they endorse the general public stereotypes about psychosis and apply it to themselves. So I think we shouldn't worry too much about stigmatising people because it's clear they're already stigmatising themselves. It's clear that the kind of levels of stigma are associated with social anxiety and depression in both samples to fairly high levels. So it's already affecting their mood and well-being. And what's clear is that coming into a trial like the EDDI trial, Regardless of condition, people's stigma comes down because we had a very normalising approach in the monitoring condition. But cognitive therapy did statistically significantly reduce stigma more than the monitoring condition. Just to emphasise the benefits of the monitoring condition as well, this is from a participant who didn't receive CBT, but they talked very glowingly about the trial and felt normal again despite not getting CBT. So just a kind of normalising, engaging approach for people at risk of psychosis also seemed to be a benefit. I shall briefly finish with a case study just to try and illustrate the complexity of some of the work. So this is a young lad I saw, had issues around self-confidence, self-esteem, low mood, harming himself, hearing voices, and what might be viewed as negative symptoms in terms of apathy and low motivation. We started with a formulation, which I'll show you in a minute, then did some work around self-esteem, helping him look at the evidence for his self-critical thoughts using a survey and so on, positive imagery in relation to some traumatic memories, which I'll say more about in a minute. So he's a lad hadn't ever felt that he fitted in at home, lots of family criticism. Everyone in his family was incredibly sporty, and he was, in his own terms, a bit of a geek. Was bullied a lot, both at school and in his first job. His issues came to a real head when he was wrongfully arrested and then subject to an awful lot of police harassment. So he used to deal with the voices by going out for walks late at night in a local park, and was wrongfully arrested and given an awful lot of grief. His experiences obviously affected the way he saw himself in the world, saw himself as different and that was a bad thing, viewed himself as unimportant and worthless, quite vigilant to danger as a result of the bullying. And that affected both current concerns about people persecuting him and the way that he was making sense of the voices that he heard, associated with a lot of low mood, anxiety, and he did a lot of things to try and control the situation that turned out to be counterproductive. So lots of safety behaviours, deliberately daydreaming and dissociating, self-harm, isolating himself, trying to stay in mental control at all times. So the work we did was based very much on that formulation, moved on to, after the kind of self-esteem work, look at his tendency to make constant negative comparisons with other people, deliberately as a strategy. Did some activity scheduling to try and increase his mood. His kind of daydreaming and dissociation seemed to fit well with the kind of GAD model, so he had lots of positive beliefs about daydreaming as a good way of reducing his distress in the moment, but he also had lots of negative beliefs about daydreaming being uncontrollable and impacting negatively as a result. Did some work in relation to the voices that he was hearing, trying to help him appraise them less distressingly, as it were, and create a sense of control. Then did some work using the Ehlers and Clark model of PTSD in relation to his traumatic memories around both bullying and the more recent stuff with the police. Then used the Clark and Wells model of social anxiety in relation to his social concerns. He had an image of himself as a very weak, vulnerable, observably stigmatized psychiatric patient. Lots of his safety behaviours in terms of arriving late to things, avoiding eye contact, only talking to people that he was familiar with. He'd speak with his hand over his mouth, did an awful lot of fidgeting, staring at the floor, hunching up, trying to just disappear, blend into the background. Some video feedback very quickly persuaded him that that wasn't a terribly good thing, and he was exacerbating his difficulties. So we ended up having about 25 sessions. In terms of the outcomes, his belief that he was good enough increased significantly, as did his confidence in social situations. He still viewed himself as different, but thought that was okay rather than a bad thing. The trauma-related symptoms and self-harm disappeared. He still heard voices, but only at night, and they were quite manageable. And he ended up engaging with education and got a girlfriend, and last time I heard from him, he's getting married. So in terms of social recovery, there was notable benefits as well. So hopefully that illustrates in a bit more detail the kind of approach that we take. Just to summarise, it's important, I think, to minimise the harm from all interventions, psychological and pharmacological, to provide people with choices and alternative options. I think it's important to normalise psychotic experiences, and certainly service users tell us that. In terms of CBT, it does appear to be able to reduce distress, but also promote meaningful social recovery. It's certainly promising for the prevention of first episode, and it looks promising in the absence of antipsychotic medication for people with established psychosis, but we need to do more research, I guess. Some psychiatrists might be concerned that if we were to do the kind of things that I'm talking about, that might discourage people from taking antipsychotic medication. I think it's pretty clear that they don't need discouraging. They tend to stop taking them anyway. And there is evidence that if you actually take a informed choice approach to discussing antipsychotic medication with people, and do it as the NICE guidelines suggest, which is information about likely side effects and likely benefits, and do it almost like a behavioural experiment, an individual experimental trial, people are actually more likely to take their medication. And there is evidence that the better your relationship with your prescriber, the more benefit you derive from antipsychotics. So I shall stop there. Thank you.